So we will continue with the antiarrhythmics. First I give the introduction. Say an abnormality in the rate, rhythm or conduction of the heart electrical impulse, that is called as arrhythmia. It can cause the heart to beat too fast, tachycardia, or too slow, bradycardia, or irregular, arrhythmia. In the tachycardia, bradycardia, the rhythm is maintained either slow or fast. In arrhythmia, the slow or fast, the rhythm is lost. Understood? That is the difference between tachycardia, bradycardia, and tachyarrhythmia, bradyarrhythmia, and so many other varieties are there. So, antiarrhythmic drugs are agents that modify the electrical impulse in the heart to restore or maintain normal heart rhythm. So suppose, as I told, the heart has to pump. If the rate increases, now suppose you told it is 72 beats per minute on an average. Suppose it becomes 200 for example. 200 means there is no time to contract and relax, just shaking. When there is no contraction, the output is not there. If the heart rate reduces also, output is not there because it is very slow, output is reduced. Fast also output is reduced because it is just shaking, not pumping. In both the cases, cardiac output is reduced, whether it is slow or fast. So here, you have to bring it to normal rhythm by giving drugs so that it can allow heart to for sufficient time to contract and relax, and make the beat come near 72. Then you get proper cardiac output. So if you see the classification of antiarrhythmic drugs, class 1, 2, 3, 4, 5. Class 1, they block the sodium channels. Class 2, beta receptor blocker. Class 3, potassium channel blockers. Class 4, calcium channel blockers. Class 5, miscellaneous. So they affect phase 0 depolarization. This will block SA0 AV node. This will usually act on the phase 3 depolarization. This will also block SA0 AV node, same like beta blocker, and this has multiple action. So, for example, if you see, again class 1 has class 1A, 1B, 1C. The different mechanism action is there, even though all block sodium channels. Class 2 beta blocker, already we told propanol, metoprolol all come from class 2. Class 3 potassium channel blocker. For your syllabus, there is one that is amiodarone, sotalol, dofetilide. In class 4, we already dealt with this diltiazem, previous class we saw, so that is a class 4. And class 5, again, multiple action. For your syllabus, we have adenosine has been given, even inosine, magnesium sulfate, all this come for class 5. So, as per your syllabus is concerned, we start with the amiodarone. Amiodarone, it is a potassium channel blocker. So potassium channel blocker is class 1, 2, 3, 4. Which class is that? Class 3. So it is class 3 antiarrhythmics. Major, it is blocking the potassium channel, but it also has action of class 1, 2 and 4. What is class 1, 2 and 4 action? It also blocks sodium channel, beta blocker, calcium channel blocker. But predominantly it is having action on blocking potassium. So if write in the exam, amiodarone is a potassium channel blockers effect and also blocks effect. Answer is over. Understood? ECG changes. Majorly, it is affecting the phase 3 depolarization. Additionally, it also acts on calcium, sodium channel blockers, affecting the phase 0, beta blocker, and calcium channel blocker, also affect the transmission impulse from SA and AV node. So that's what we get there. They increase the action potential duration and QT interval. So you know that action potential duration. So this is the action potential duration. So you know absolute refractive, so from here absolute refractive period, then relative refractive period, both together called effective refractive period, action potential duration. And also we have, it affects the QT interval. So you know the ECG, P, Q, R, S, T. Q to T is interval. It affects that. You know why it is called as P wave? In the ECG, start with the letter P alphabet. Why P? Why not A, B, C, D? A, B, C, D is up with Z, isn't it? Why it starts with P? Anybody thought about this? See, somebody told I will learn. You should think. Why? Unless whatever learning, if you don't know why, what, how, so don't have all these such of questions, you will not learn. Sir, I know ECG, I know start from PQ, RST. Why not from A, B, C, D? Or XYZ, or 1, 2, 3, 4, why you start with P? No idea? But this I learned when I was studying. You should not learn after you become faculty somewhere. So that's why I'm teaching you normally. Now if you take this line, this is called baseline. You keep it as 0. Understood? So if this is the baseline, you start with 0. So this is 0, isn't it? So in ECG, the first wave, so this is plus, this is minus. The first wave is towards positive P, and you continue, that's all. Simple. Understood? Very simple it is. Because first wave was positive, we start with the P, then all other waves, suppose if you would have like this another few waves in case, so P, Q, R, S, T, U, V, W, X, Y, Z, you would have continued. But it stopped here, again it becomes like this. So then they came to know that, oh, this is repeating. So every wave, PQRST is going on. So we keep as PQRST, that's all, simple. So who was the scientist who gave this? You know the scientist name? He died. Okay. Papa, something he gave to students and they forgot it. Emergency use. We can use in ventricular fibrillation, which is respiratory shock, pulses, ventricular tachycardia, then hemodynamically unstable ventricular tachycardia. These are the different types of arrhythmia. In all these things, the rate is very fast because of you give this drug coming little lesser and matching with normal ECG or action potential. So loading dose, you can give 300 mg over 20 to 60 minutes, maintenance 900 mg over 24 hours, oral also can be given. Come to adverse effects, blue chip, remember the pneumonia, bradycardia, liver toxicity, in eye it may cause corneal micro deposits, cornea, so they may have some difficulty in seeing and long term use. Cutaneous, blue-grey skin pigmentation. Hypothyroidism or hyperthyroidism. I will tell you why this drug will affect the thyroid gland. Pulmonary fibrosis and skin photosensitivity. Means you take this drug and go to sunlight, you get rashes. This is photosensitivity. Contraindication, don't give information, only have bradycardia, AV block, severe hypertension, iodine allergy and thyroid dysfunction. You should not use this drug, amiodarone. Amiodarone is a very, very important drug. Always they ask for medical students. So precautions, frequently monitor thyroid function test, liver function test, ophthalmological examination, ECG and QT interval. Long QT interval also will cause again. And remember, all anti-arrhythmic drugs This is a universal statement. Suppose you know that drug is having antiarrhythmic action, but I forgot the adverse effects. Suppose you forgot. Understood? You know the drug is antiarrhythmic. I know everything, but I forgot the adverse effects. You can write this by closing your eyes. All antiarrhythmic drugs will themselves causes they themselves cause arrhythmia. If you overdose, too much of prolongation of APD or too short APD can occur because it's a drug. You are given overdose. So all antiarrhythmic drugs themselves can cause arrhythmias adverse effects. Similarly, all anti-cancer drugs can themselves cause cancer. That is a chemotherapy issue. But still, this is a statement. Now, why you should be very careful in patient who has some thyroid function disorder? Amiodarone contains 37% iodine by weight. This iodine overload can disrupt normal thyroid function, leading to hypo or hyperthyroidism. Your thyroid gland has some limit to take the iodine. See, your thyroid gland will take iodine only if it wants to synthesize the hormone, thyroid gland, in the neck region. So, what are the iodine we have in the food? If the hormone is deficient, then only iodine will be taken up. If there is excess of iodine, the hormone release gets stopped. There is lots of physiology is there in this and biochemistry. Excess of iodine also will inhibit the T3 T4 hormone release. So if you give this drug is already containing iodine, so that becomes excess. What it is getting from the food, this drug is getting add on to that, and the gland releasing of this can be disrupted. Now you may ask, sir, then how it can be hypo or hyper? Either it should cause one, either hypo or hyper. How it can cause both? It depends. Why? Because the thyroid gland in the neck region, the thyroid gland, whether it's hypothyroidism, the gland will swell. Hyperthyroidism, the gland will swell. Thyroid cancer, gland will swell. So one patient came with gland swelling. How you know it is hypo, hyper, cancer? In all the three, swelling is there. Understood? Patient don't know whether he has hypo, hyper. So you have to do investigation, see. Now what is happening here? With also we have autoimmune antibodies. In that we have some condition called Hashimoto's thyroiditis or Graves' disease. This is nothing but these two are the auto-antibodies that is produced against our body tissue only to destroy. Now how the thyroid hormone is getting released and what is happening? Now this is the hypothalamus and this is the pituitary gland and this is the thyroid gland. Okay. Now hypothalamus will release one hormone called as TRH, thyroid releasing hormone or thyroid releasing hormone. Pituitary gland will produce TSH, thyroid stimulating hormone, and by taking iodine, the gland will produce T3 and T4. T3 is 5% and T4 is 95%. But this is always stronger. This is the one acting. T4 will not act, it will be in the circulation. If you want T3, 1/4 should be reduced minus 4 minus 1. Then it becomes T3. Then it acts. You have to remove one iodine from this. Then only plant. So once the action is over, you will write letter. My action is over. You stop. Just for feedback inhibition. Now, for example, you read the iodine. Iodine is not there in your food stuff like in the salt. So T3, T4 hormone is not there, right? When T3, T4 hormone is not there, nobody will write letter, correct? Because it's not there, so nobody is writing. And these two will think, why nothing influence is coming? So what we do? We will produce more and more TRH. TSH will stimulate more and more TSH, and TSH is coming and stimulating gland. Now gland is telling, I don't have iodine, I can't synthesize. So because he is putting more pressure, the gland will swell. So iodine deficiency, hypothyroidism, goiter. This is called as goiter. What is one thing? Second one, Hashimoto's thyroiditis. Autoimmune antibodies comes and destroys some part of the gland or whole gland. They come and destroy the gland. When the gland is destroyed, again no T3, T4. Yes or no? Nobody is writing a letter. Again same mechanism. Gland will swell. Correct? There is a. Then Graves' disease. In this case, it will come and tell the gland to produce more and more T3, T4. Extra, it is telling that you synthesize more. I want it. So, because of extreme tension from the outer, not from the pituitary gland, autoantibody only, the gland will swell. Yes or no? Whereas in case of, so I will give this here, how you can see the test and come to know. See, iodine deficiency. We talked in terms of only TSH and T3, T4. TSH, T3, T4. Okay. Iodine deficiency. What is the level of TSH? Increase or decrease? TSH increase or decrease? Increase. T3, T4? Wrong hypothesis. It's no. So decrease. Got it? Then we put one is lower. Number one is lower. Hashimoto thyroiditis. TSH increase or decrease? Increase. T3, T4? Decrease. Same. Graves' disease. TSH I told the autoantibodies coming and stimulating more and more. So it will become ulta here. T3, T4 increase. Because they are writing letter, TSH is not produced because anyhow sufficient is why you should do it. So T3, TSH will be decrease. Understood? Whereas in case of cancer, this is the gland, this is external, this has become carcinoma, cancer. So if normally T3, T4 produce 100% here, because of cancer it is producing 150%, for example. So what about T3, T4? This extra is 0. T3, T4 increase. TSH decrease. So, then we have to do additional test to confirm whether it's hypo or hyper. Why it is hyper? What is hyper? We do other tests to know the autoantibodies. We do the anti-TPO test, thyroid correction. So many other tests are there to confirm what kind of. But in all the case, we saw what gland is swollen. Understood? Then we do differential diagnosis. Now come to the next word, adenosine. Adenosine. So this comes from the class 5 antiarrhythmics, or you can also consider miscellaneous. As per textbook, we have only 4 classes, class 1, 2, 3, 4. Class 5 is just we are kept like that, under miscellaneous. So even if you don't write any class for this, we don't mind. You have to at least write antiarrhythmic mechanism. It acts on the A1 adenosine receptor on the AV node. Then decrease cyclic AMP, slows the AV nodal conduction and interrupts the re-entrant pathway. What is the re-entrant pathway? It's a nice concept is there. What is the re-entrant pathway? Now this is the conducting system of the heart. One impulse is coming like this, okay, to a particular portion of the heart. When the impulse comes, it divides. Okay, then this impulse is passing like this, and that impulse is going that way, right? So this impulse goes like this. It will come here and can read here. So when the impulse is coming in equally distributing all over the body, heart body surface, you are getting normal conduction. For example, here actually this impulse should not come back to the same place where it has come from. Okay. For example, there is a block here. For some reason there is a block. So one impulse coming here, split. This has got obstruction here. Yes, but this is moving. Correct? It came here, one went here, splitting, and is coming back. It's coming back here because nothing is coming from there. It can come here and split like this. You know, this is going there, but this is again coming back. And coming back because block is there. Here slowly it moves. Very slowly it moves. Once it comes to normal tissue here, start moving again here and again come back. Again, this becomes chain process. And this is called as re-entrant. Understood? It should not come back actually. Because there was a heart block was there and the impulse, nobody is there to neutralize this impulse, again come back, come down, and this becomes chain set of motion, and that is called as re-entrant pathway. In that case also, you can use adenosine. So it is a drug of choice. Whenever adenosine acts, you please write this word. PSVT is very, very important. Paroxysmal is again and again. Paroxysmal. Supraventricular tachycardia is a drug of choice. Diagnostic aid in wide complex tachycardia, temporary block for ECG clarity. So you IV bolus only rapid push. 106 mg. So you can see the dose. So I am not going to detail about the dose. Flush D, just adverse effects. Flushing, lightheadedness, ECG changes, shortness of breath, hypertension, dyspnea, and just discomfort. And contraindication, you should not give in second and third degree heart block. You can't study the degrees of heart block. First degree, second degree, third degree, fourth degree. Note the difference between the heart blocks. We have to make a chart. Degrees of heart block. You will go to the Google, type degrees of heart block table, click on the images, you get on images. Copy and to your notes. Here they put degrees, what is happening and what is the ECG changes. So you can use in first degree heart block, not in second and third. The extreme block is there, if you use, no use. So that is the contraindication. Come to next topic, glucocorticoids. It's a hormone. That is over. Your CVS is over. Next topic we have to deal with glucocorticoids. These are class of corticosteroids hormones that are either naturally produced by the adrenal cortex, example cortisol, or synthetically made, example prednisone, prednisolone, dextrose, metazone. They play a key role in regulating metabolism, immune response, and body stress response. So whenever you have stress, the corticosteroids helps you combat the stress or cope up with the stress. If the corticosteroids is not there, then you will collapse. So that is the function of, it is also a stress hormone. Remember the pharmacogeneration, if either it is produced in the body or you give as a drug, what and all it does. Remember pig fishing. Increases blood pressure mechanism, increase vascular responses to catecholamines like adrenal noradrenaline will act with high power only if corticosteroids is there. If corticosteroids is not there, then adrenal is not having that much power. Increase insulin resistance and decrease peripheral uptake of glucose because hyperglycemia, cope up with the stress. G, increase gluconeogenesis, again hyperglycemia. F, fat distribution. If you give this drug for longer time for a patient will have central obesity, moon face, buffalo hump. Here it will be like fish mouth, purpose face. So type in the Google Cushing syndrome and click. you get the persons who looks similar to these symptoms. Find out that in Google. Just write in the Google images Cushing syndrome and click on the images and see how they look. I'll show one of the images what I have given in my textbook. I inhibit T cell activation cytokine, so immunosuppression. So those who are on these glucocorticoids, they are susceptible for infection. You always watch on that. Increased bone resorption, they always have bone weakness because the calcium is removed from the bone and put to the system circulation. So bone become weaker. Head androgen excess, it may cause excess facial growth for females, even on the face. Irritated effect cause gastritis, necrosis, avascular, especially the femur bone, so that may get fracture. And G, inhibit growth hormone. It may, if you use this for longer time in children less than 18 years, they may have stunted growth. So these are the pharmacological action of glucocorticoid. How does it act? Glucocorticoid enter the cell, bind receptor, forms a complex. The complex will become double dimerization, transcript nucleus, bind to specific element of GNA called as glucocorticoid response element, synths of mRNA, goes into this ribosome, synthesize the protein will give a response, and this response is action of glucocorticoid. Previous slide, what all we told, that is the action of glucocorticoids, and that is because of this. Once a glucose is stimulated, release that in this pathway. You can write this in the examination, may not be this, that in the examination. Now, what is available in the market? You can see it. Either you can classify based on the duration. All are having the same action, but the duration may differ. Short acting, intermediate, long, and this inhalational. So short acting may act for 2 to 3 hours, 4 to 6 hours, 12 to 24 hours. This is given inhalation. Whereas you can see the uses of glucocorticoid, I kept the mnemonic corticosteroids. These are the uses. You can use cerebral edema, organ transplant rejection. Whenever you transplant organ, the recipient body may reject the organ. When it's rejecting, it produces more and more inflammatory mediators and allergic reaction can occur. You can give the first steroids, suppress the immune system, then you can transplant organ till the body accepts the new organ. Then rheumatoid arthritis and other autoimmune disease, because it suppress the inflammation and it suppress the immune system. Thyroiditis, itis, inflammation, you can use there. Inflammatory bowel disease, inflammation is there. These two are long-term effect in the colon. Patient may have diarrhea, constipation. Chronic obstructive pulmonary disease, asthma. Asthma also inhalation. They use that. So reduce the edema, pulmonary edema. Ophthalmic inflammation. We have eye drops, corticosteroid eye drops on there. Dexamethasone. Skin disorder. You go to any dermatologist, any skin the itching, then allergy and all. They start with these corticosteroids initially. They are not going to first treat the disease. Disease is treating later. Symptomatically, this will bring down the skin flares. And tubercular meningitis and pericarditis. Actually speaking, you should not use corticosteroids in patient who is having tuberculosis. Tuberculosis will spread faster if there is immunosuppression. This drug will cause immunosuppression. Usually you should not use. But in a serious condition, because itis is there, inflammation can use in special condition in tubercular. You know, during COVID-19, they use this highest number, corticosteroids, because whole lungs got inflamed and all the pulmonary vessels and the arteries are got fully constricted. Bronchus and all got constricted. So because of that, what happened? Patient couldn't able to breathe. So they use high dose of corticosteroids. Many of the patients still are having now the adverse effects of corticosteroids, increase in body weight, hypertension, hyperglycemia, osteoporosis. Respiratory disorder, this is a preterm infants, you can use this. Oncology related lymphoma, leukemia, because we want to reduce the lymphomas. Immune thrombocytopenia, dermatitis, shock also you can use this. Then you may ask, sir, everything should I remember? For you are writing emergency, you can use it there. Organ transplant rejection, tubercular meningitis, respiratory distress in preterm infants, oncology related. So these are all some of the things where we are going to use this in exclusively the corticosteroids. Come to the adverse effects. Again corticosteroids. Cushing's features, already for Cushing's syndrome, that you can write. Osteoporosis, you know that. Retard of the growth in children, right? It causes that. Then thinning of the skin becomes very thin and usually gets wound. Infections, I told it causes immunosuppression, infection. Then cataract and glaucoma, you should not use for long time. Patient should not able to see properly. Cataract because where the opacity of the lens occurs. Then obesity because of the Cushing syndrome. Stomach ulcer, gastritis causes. Then tendon rupture, muscle wasting, patient emotional disturbance, rebound effects. If you stop taking the corticosteroids immediately, it again causes a condition called as HPA axis suppression or acute withdrawal syndrome. Now here the hypothalamus, pituitary gland and adrenal gland. So this is producing what? CRH, corticotropin releasing hormone. This is producing ACTH and this is producing corticosteroids. Now same like previous one, once the action is over, feedback inhibition. Okay, patient got something disease and you start giving corticosteroid outside to treat this. Now when you are giving from here, the body production of corticosteroid gets stopped because he thinks that anyway you are giving, why you should produce? Then it stops. When this patient was taking for 6-7 months, suddenly he stopped without telling the doctor. You know, in the body it's not synthesized. Every day you are exposed to stress. Once you expose to stress, the hormone is not there, zero, and you go for shock. And that is called as HPA axis. Hypothalamo, pituitary, adrenal axis suppression. So whenever you want to stop the corticosteroids, tell the patient to gradually taper down the dose. 1 milligram is 0.75, 0.5, 0.25, 1. Maybe with 1 to 2 months, slowly. So that whatever the portion you are stopping here, this portion is stopped. Here this portion starts producing. Then you stop half. Here half produces. Then 3 by 4. 3 by 4. Then you stop here. Complete take control function. Finish. So that's why abrupt withdrawal of the corticosteroid should not be done. Gradually taper the dose if you have used the drug for longer time to a patient. There is a precautions. So that's why it called rebound. Understood? Sudden stop. Then edema, diabetes, delayed bone healing, and suppression of HPA axis already. These are the adverse effects of corticosteroid. Any 5 you can write in the exam. You read all the things well and good. Cushing syndrome. You will get a real picture in the Google images. You can see that how the patient only looks. Contraindication, super. What is super here? Should not use it. A patient already has systemic fungal infection because if it suppresses immune system, the fungal infection will increase. Uncontrolled diabetes and hypertension, peptic ulcer, emergency case of recent surgery or wound because you did surgery on a patient wound, it not heal only. Then recent also tuberculosis should not use. I have been given for you to take few drugs among these 4 drugs are there. Hydrocor, everything is same. The drugs are different. That's all here. So if you see the classification here, see hydrocortisone is there here, prednisone is here, methylprednisolone is here, and budesonide is here. These 4 drugs have been given dealt with. So all the things are same. Only if you see the drug wise, it is different. Little bit different means see class short acting. Use adrenal insufficiency, anaphylaxis, septic shock, topical use can use in like ointment, gels, creams, lotions are available. You can use in skin line. So orally is available, topical is available. Duration is short acting, 8 to 12 hours over. That's all hydrocortisone. Otherwise, everything what I told previously, same thing you are writing. Pharmacological action, adverse effects, content, everything is same. The drug is different. This is short acting. This is a single drug, so nothing else to tell more. Come to next one, dexamethasone. This is long acting. See, I told they use this in even severe COVID-19. Dexamethasone. Cell edema, nausea in chemotherapy. Whenever you start with anti-cancer drug, patient have excess of nausea and vomiting. They have used this drug, dexamethasone. Oral IV, and 36 to 72 hours it acts. If you take one dose, 3 days, 3 to 4 days it acts. Per oral IV for 10 days can be given. This drug, dexamethasone, very important, available as tablets and injection. Dexona, 0.5 mg is there available. If you get immediate rash, no, you had some prawn or somewhere you went near the forest area, you got some hair. Immediately you take these two. You should tell me what I am writing correct. You will see who will remember. Take tablet Avil and tablet Dexona immediately. Even any bee sting or some scorpion bite, what I will contain? What it contains? What is the chemical name? Generic name? I know you will not tell. What is it? See, everybody, my son also will tell by seeing the book. My son is 5th standard. He will see and tell. Without seeing it, you are the past. Tell me what it contains. Phenyramine. Phenyramine. When we used to practice a few years back, we used to write like this. Tablet CPM. Phenyramine maleate. You know, that time 1000 tablet cost, 1000 tablet of CPM cost 30 rupees. For patient, we used to give 3 tablets. Even this can be used in case of cough, cold and allergy. Understood? 3 tablets, one patient 3 tablets. I have 1000 tablets, 30 rupees. Gobi manchuri cost? 1 plate? 50. Where is 1000 tablet 30 rupees? 1 plate cost 50 rupees. See the difference. If you give 3 tablets to one patient, for 1000 tablets, how many patients you can give? Yes, you work out and see that many days we can get the, and one patient will give usually consultation fees of around 100 to 200. And the CPM was available in the 4 to 5 colors: white, pink, green, blue, yellow. Okay, so if you get even one box with this, we used to intermix or interchange the colors and give to the patient. They should not know, this color is there. I got the same color. No, I got different color, but drug is same, color is different. Some people have fancy for color. You give blue, no, I should match with my saree color, so I will take this. Fashion. Okay. Methylprednisolone, intermediate acting, 18 to 36 hours. Severe asthma, autoimmune flares, multiple sclerosis relapse, transplant rejection, spinal cord injury, all these things. On a whole, I will tell you, if there is extreme inflammation inside the body, irrespective of the cause, I don't know what is the cause, but there is inflammation, edema, inflammatories are released, then they use corticosteroids. Whether there is a problem in the spine, or in the brain, or in the bladder, or anywhere, usually we have something called as inflammatory markers. If that is the patient has body pain or some other symptom, we are going to check these inflammatory markers like interleukin, then C-reactive protein. If these are increased in the blood, means patient has inflammation inside the body, which I can't see from outside. I can see only with this marker and tell. Then they start with corticosteroids. This is called as life-saving drug, corticosteroids. Remember this. Many people got saved of life because of using corticosteroids during COVID condition. Now they may be suffering with some other condition, but they are still alive. Not died of COVID-19. This as rescue. Last drug under this corticosteroid is budesonide, glucocorticoid, and it is available as inhaler or inhalation route. Available as oral, rectal and nasal also, nasal spray. The prime use is in asthma. Onset cures, it will act for 7 days. It's intermittent acting, and we are given here DPA-MDA. You know what is DPA-MDA? So you can see the DPA-MDA means DPA, dry powder inhaler, available in the market, contains budesonide as a dry powder activated by patient's own inhalation. First you have to exhale, keep it and inhale. Requires deep forceful breathing, no propellant used in this, you don't press it like this. Metered dose inhaler delivers a fixed dose of budesonide in aerosol form using a propellant gas, like your deodorant is like that. Requires coordination between actuation and inhalation. See, when you press and inhale should be proper, otherwise drug is first and you need inhale, or inhale then you press it, it become incoordination. This is all used in asthma, not in acute attack. In acute attack of asthma, you have to use one more drug that I am going to deal later, called a salbutamol. It's a bronchodilator. This drug is not a bronchodilator. They don't dilate the bronchioles, but they reduce the edema because of inflammation in the bronchus. So you can use this drug for maintenance. Immediately to control, you can use bronchodilators. So we have deriphyllin, which contains theophylline, or salbutamol that I am going to take later. There is bronchodilator. And this drug, once it comes under control for long-term maintenance, you have to use this. But one more thing. Now you should tell me. I am going to stop right there this time. No? Suppose you have inhaled like this, either this or this. The drug will act locally in the lungs. You should not go to systemic circulation. If you go to systemic circulation, you get all the adverse effects. I want the drug to act only in the lungs. It acted. Now you tell me what danger you expect from this.